Hello students, after studying pathophysiology of pulmonary tuberculosis in our last video, in today's video we are going to study pharmacology of anti-tubercular drugs, a complete comprehensive overview. Now by now we know tuberculosis is also known as TB, and TB is a chronic granulomatous disease. It is caused by infection due to a bacteria known as Mycobacterium tuberculosis. Now this bacteria is also known as tubercle bacilli. Now look at this figure. Lesion produced by infection due to tubercle bacilli is known as granuloma, and thus TB is known as a granulomatous disease. Now this bacilli is a respiratory pathogen that primarily affects lungs, and therefore the disease is known as pulmonary tuberculosis. Now when this bacilli affects other organs like bones, joints, central nervous system, urogenital tract, kidneys, etc., that is organs outside the lungs, then TB is known as extrapulmonary TB. Another type of life-threatening and potentially fatal TB is the miliary TB. Now it occurs when a large number of tubercle bacilli pass into the bloodstream and is spread throughout the body. Now let's talk about the Mycobacterium tuberculosis. Now this mycobacteria is rod shaped. It's highly aerobic and it grows very slowly. Now this bacteria possesses a very complex cell wall structure, and it is made up of 5 main tissue layers. Innermost is the cell membrane. Then cell membrane is covered by the peptidoglycan layer, which in turn is covered by the arabinogalactan layer, and arabinogalactan is further covered by the mycolic acid layer, and the outermost is the capsule. Now this complex cell wall structure, and especially this thick mycolic acid layer, makes the bacteria resistant to antibiotics, and thus tuberculosis requires long-term treatment with multiple drugs. Now anti-tubercular drugs can be classified as first-line drugs and second-line drugs. First-line drugs are mainly commonly used for the treatment of TB. These are highly efficacious with low toxicity. Now, second-line drugs are used as reserve drugs, as these drugs have lesser anti-tubercular efficacy and their toxicity is high. Now, these drugs are used for the treatment of multi-drug resistant TB. Now, first-line drugs are rifampicine, isoniazid, pyroxenamide, ethylbutol and streptomycin. Now, we can remember these drugs by the mnemonic RIPES, R-I-P-E-S. Now, second-line drugs are ethionamide, then prothionamide. Prothionamide can be used as an alternative to ethionamide. Then cycloserine, terizidone. Terizidone consists of 2 molecules of cycloserine, and terizidone can be used as an alternative to cycloserine. Then paraamino-saliculic acid, in short PAS. Then fluoroquinolones like ofloxacin, levofloxacin, moxifloxacin and ciprofloxacin. Now here moxifloxacin is the most effective fluoroquinolone against Mycobacterium tuberculosis. Then injectable drugs include aminoglycoside antibiotics, namely kanamycin, amikacin. Now let's discuss pharmacology of each of these anti-tubercular drugs. Our first drug is the rifampicine. Now rifampicine is a highly efficacious anti-tubercular drug. It is bactericidal. It kills Mycobacterium tuberculosis. Then mechanism of action of rifampicine. Rifampicine inhibits mycobacterial DNA dependent RNA polymerase enzyme. So this enzyme is inhibited by rifampicine. Now RNA polymerase enzyme, or this enzyme, it reads DNA and it makes RNA, particularly messenger RNA. So inhibition of this bacterial enzyme inhibits synthesis of RNA. Now this further inhibits synthesis of bacterial protein, essential for the bacterial growth and multiplication. Now rifampicine is very effective. Now rifampicine kills intracellular as well as extracellular bacilli. That means it kills bacilli that is engulfed by macrophages as well as the bacilli which are present outside the macrophages. So rifampicine acts both intracellularly as well as extracellularly. Then pharmacokinetics of rifampicine. Rifampicine is very well absorbed orally, but absorption is reduced by the presence of food in the stomach. So rifampicine should be taken in empty stomach. Then rifampicine is lipophilic and it is widely distributed in all tissues and body fluids, including cerebrospinal fluid. Then it is metabolized in the liver and its half-life is around 2 to 5 hours. It is mainly excreted in the feces and some of it is excreted in the urine. Now drug interactions of rifampicine. Now rifampicine is a microsomal enzyme inducer. It increases the activity of cytochrome P450 isoenzymes. Now this increases metabolism of drugs like warfarin, then oral contraceptives, phenytoin, corticosteroids, HIV protease inhibitors, etc. These are very important drug interactions of rifampicine. Then adverse effects of rifampicine. Hepatitis. Hepatitis is the major dose-dependent adverse effect of rifampicine. Another characteristic adverse effect of rifampicine is orange-red to orange coloration of body fluids. Body fluids like urine, saliva, sweat and tear. Now this adverse effect is harmless, but the patient should be well informed in advance about this adverse effect to prevent anxiety in the patient, to prevent fear in the patient. Then rifampicine can also cause minor reactions. Cutaneous syndrome, that is adverse effect related to skin like flushing, that is the redness of skin, pruritus, that is itchy skin, itching. Then flu syndromes characterized by chills, fever and headache. Then abdominal syndrome characterized by nausea, vomiting, cramps, etc. So rifampicine is a first line anti-tubercular drugs. It is an excellent drug. It inhibits synthesis of bacterial RNA and it exerts bactericidal effect. And main adverse effect is the hepatitis and orange-red to orange coloration of body fluids. So this is the pharmacology of rifampicine. Now another highly efficacious and an excellent first line anti-tubercular drug is the isoniazid. Now chemically isoniazid is isonicotinic acid hydrazide, in short INH. It is tuberculocidal. It kills Mycobacterium tuberculosis. Now let's understand mechanism of action of isoniazid. Now as already discussed, mycolic acid is a unique fatty acid and is a very important component of mycobacterial cell wall. Now isoniazid inhibits synthesis of mycolic acid. Now isoniazid is a prodrug. It is not active on its own. So isoniazid enters the mycobacterial cell and mycobacterial catalase peroxidase enzyme convert isoniazid to a reactive metabolite, namely N-acetyl isoniazid. Now N-acetyl isoniazid binds to NAD and forms an adduct or forms a complex, and this complex inhibits bacterial INHA and Cas-A genes. Now these genes are required for the synthesis of mycolic acid. So inhibition of these genes inhibit the synthesis of mycolic acid. So this is how isoniazid inhibits the synthesis of mycolic acid. In addition to this, N-acetyl isoniazid also forms complex with NADP, and this complex inhibits bacterial dihydrofolate reductase enzyme, which is required for the metabolism of folic acid by the bacteria. And folic acid is required for the synthesis of purines and pyrimidines. Purines and pyrimidines are the component of DNA. So inhibition of dihydrofolate reductase by isoniazid inhibits synthesis of bacterial DNA. So isoniazid inhibits synthesis of mycolic acid and also inhibits synthesis of bacterial DNA, and it produces a bactericidal or tuberculocidal effect. Now in addition to this, very important, isoniazid kills Mycobacterium present both intracellularly as well as extracellularly. Now let's study pharmacokinetics of isoniazid. Isoniazid is completely absorbed on oral administration. It is widely distributed in all body tissues. It is extensively metabolized in the liver via acetylation. Now this acetylation is genetically determined. So individual can be a fast acetylator where isoniazid is metabolized rapidly, and therefore the half-life is only of 1 hour, whereas slow acetylators are those individuals where isoniazid is metabolized slowly, and therefore the half-life increases to around 3 hours. Now in addition to this, isoniazid is excreted renally through the kidneys. Then drug interactions of isoniazid. Now isoniazid is an enzyme inhibitor, and therefore it produces drug interactions. Now isoniazid inhibits cytochrome P2C19 and cytochrome P3A4 enzymes. Now inhibition of these enzymes reduce metabolism of drugs like phenytoin, carbamazepine, diazepam, warfarin, etc. So these are the drug interactions of isoniazid. Then adverse effects of isoniazid. Now a very important adverse effect of isoniazid is the peripheral neuritis, that is inflammation of peripheral nerves. And this is a very important dose dependent adverse effect of isoniazid. Now this peripheral neuritis can cause numbness, that is loss of sensation. It can cause problems like mental disturbances. Now supplementation of pyridoxine or vitamin B6 with isoniazid prevents this neurotoxicity. So whenever isoniazid is consumed or whenever isoniazid is given, it should always be supplemented with pyridoxine. Another very important adverse effect is the hepatitis. Hepatitis is also caused by the rifampicine. This hepatitis is reversible, so it gets reversed on stopping the drug. Other side effects are lethargy, then rashes, fever, acne, and arthalgia, that is joint pain. So isoniazid is an excellent anti-tubercular drugs. It inhibits synthesis of mycolic acid. It acts both intracellularly as well as extracellularly. It is bactericidal, and it shows drug interactions. And two very important adverse effects of isoniazid is the peripheral neuritis and hepatitis. Now the next first line anti-tubercular drug is the pyroxenamide. Now pyroxenamide is chemically similar to isoniazid. It is weakly tuberculocidal. That means at high concentration it kills Mycobacterium tuberculosis. Now like isoniazid, pyroxenamide is also a prodrug. Now it also enters the bacterial cell. So inside the mycobacteria it is converted to its active metabolite, that is the pyrazinoic acid, by mycobacterial pyrazinoamidase enzyme. Now this active metabolite pyrazinoic acid inhibits enzyme fatty acid synthase. Now this enzyme fatty acid synthase is essential for the synthesis of fatty acid mycolic acid. Now as we know, mycolic acid is a unique, very important component of mycobacterial cell wall. So like isoniazid, pyroxenamide also inhibits synthesis of mycolic acid by inhibiting the enzyme fatty acid synthase and exerts a weak bactericidal effect. Now along with this, pyrazinoic acid also disrupts or it also interferes with the mycobacterial cell membrane, and it also alters or changes or interferes with the transport functions of this cell membrane. So this is the mechanism of action of pyroxenamide. Now very important, pyroxenamide acts only intracellularly. Now important pharmacokinetic parameters of pyroxenamide: it's rapidly absorbed orally, it is widely distributed in the tissues and fluids including cerebrospinal fluid, and thus it is very useful in meningeal tuberculosis. It is extensively metabolized in the liver. Its plasma half-life is 6 to 10 hours and it is excreted in the urine. Then adverse effects of pyroxenamide. Now most important dose related adverse effect is the hepatotoxicity. So now you can see that hepatotoxicity is caused by isoniazid, rifampicine as well as with the pyroxenamide. Now another important adverse effect is the hyperuricemia. So it causes hyperuricemia by inhibiting the secretion of uric acid in the kidneys, and this hyperuricemia can cause gout. Then other side effects include abdominal distress, then arthalgia, that is the pain in the joints, flushing, rashes, fever, then loss of diabetes control. Then safety of pyroxenamide is uncertain during pregnancy. So like isoniazid, pyroxenamide also inhibits synthesis of mycolic acid, and it is also tuberculocidal, and it acts only intracellularly. Its main adverse effects include hepatotoxicity and hyperuricemia. So this is the pharmacology of pyroxenamide. Now the next first line anti-tubercular drug is the ethylbutol. Now unlike other first line anti-tubercular drugs which are tuberculocidal, ethylbutol is tuberculostatic. It cannot kill but inhibits growth of Mycobacterium tuberculosis. Now ethylbutol is added to the triple drug regimen consisting of 3 drugs, namely isoniazid, rifampin and pyroxenamide. And then these 3 drugs along with ethylbutol are used for the treatment of active tuberculosis. Now here the main purpose of adding ethylbutol is to prevent development of resistance by the bacteria against all these drugs. So ethylbutol prevents development of resistance by the bacteria. Now mechanism of action of ethylbutol. Now if we recall structure of Mycobacterium tuberculosis, besides mycolic acid, arabinogalactan is also a very important component of Mycobacterium tuberculosis cell wall. Now, ethylbutol inhibits enzyme arabinosile transferase, thereby inhibiting synthesis of arabinogalactan, and this further inhibits incorporation of mycolic acid in the mycobacterial cell wall. So, this is the mechanism of action of ethylbutol. Now, very important, ethylbutol also acts both intracellularly as well as extracellularly. Then some important pharmacokinetic features of ethylbutol. About 3/4 of the oral dose is absorbed. Then it is widely distributed in the body, but it incompletely penetrates the meninges. Then less than half of the ethylbutol is metabolized. It is excreted in the urine, and plasma half-life is around 4 hours. Then adverse effects of ethylbutol. Now, the most important adverse effect of ethylbutol is optic neuritis, where toxicity is dependent on the dose and the duration of the therapy. Now, optic neuritis is the inflammation of optic nerve of the eye. Now, this optic neuritis can cause loss of visual acuity, that is loss of sharpness of the vision. It can cause color vision. It can also cause field defects. Now, the drug should be stopped at the first sign of visual impairment, and therefore this drug should be avoided in children, as children are unable to report the visual impairment. Now, if the drug is stopped in time, then visual toxicity is largely reversible. Then this ethylbutol also interferes with the urate excretion, and it can cause hyperuricemia. Then other adverse effects are rashes, then fever. Rarely, sometimes it can cause peripheral neuritis. So, these are the adverse effects of ethylbutol. So, this is the pharmacology of ethylbutol. Now, the next first line antitubercular drug is the streptomycin. Now, streptomycin is tuberculocidal, but it is less effective than isoniazid and rifampicine. Now, it acts only on extracellular bacilli, and it is administered by intramuscular route. Now, let's study mechanism of action of streptomycin. Now, streptomycin is an aminoglycoside antibiotic, and it inhibits synthesis of bacterial proteins. Now, look at this figure. This is the bacterial ribosome, and this is the messenger RNA, and these are the codons on messenger RNA. Now, as we all know that for the synthesis of proteins, messenger RNA binds to 30S ribosomal subunit of the bacteria. Now, on the P site of ribosome is present the transfer RNA with the elongating peptide chain. Now, this peptide chain elongates, and finally the protein is synthesized. Now, codons on messenger RNA are red, and accordingly transfer RNA brings required amino acid, and this amino acid is then added up to this nascent peptide chain, and the peptide chain elongates. Now, streptomycin binds to 30S ribosomal subunit. Now, what streptomycin does is this, that it causes misreading of messenger RNA codon. So, because of the misreading of these codons, wrong amino acid is added to the peptide chain, and therefore non-functional bacterial protein is synthesized, and this causes death of bacteria. And this is how streptomycin produces tuberculocidal effect. Then major adverse effects of streptomycin: ototoxicity, that is toxicity of the ear; nephrotoxicity, that is toxicity of the kidneys. Now, because of the toxicity, use of streptomycin is restricted to a maximum of 2 months. Now, besides this, streptomycin is used only as a supplement first line drug. That means it is used only if it is required. For example, in the case of refractory tuberculosis. So, this is the pharmacology of streptomycin, and by now we have discussed pharmacology of all 5 first line antitubercular drugs, namely isoniazid, rifampicin, ethylbutol, then pyroxenamide and streptomycin. Now, let's discuss treatment of active tuberculosis and latent tuberculosis. Now, active tuberculosis is symptomatic. It shows symptoms and is communicable, that is, it is transmittable. Now, active tuberculosis includes all new cases of sputum smear positive individuals, then patients with severe pulmonary TB, then patients with severe form of extrapulmonary TB. Now, treatment of active tuberculosis is done in 2 phases. Now, initial intensive phase with 4 drugs, namely rifampicin, isoniazid, pyroxenamide and ethylbutol along with vitamin B6 supplement to prevent neurotoxicity of isoniazid. Now, this initial treatment is given for the first 2 months. Now, this treatment causes rapid killing of Mycobacterium tuberculosis bacilli, and this provides symptomatic relief. Now, this initial intensive phase is followed by the continuation phase with 2 drugs, rifampicin and isoniazid along with vitamin B6, and these 2 drugs are given for the next 4 months. Now, purpose of this continuation phase is to kill remaining bacteria and completely cure the disease so that it does not occur again, and this prevents the relapse of disease. So, this is the treatment of active tuberculosis. Now, latent tuberculosis. Now, latent tuberculosis is when Mycobacterium tuberculosis become dormant. The bacteria does not multiply. Now, latent tuberculosis is asymptomatic and it is non-communicable. It cannot be transmitted, it cannot spread. But during the lifetime of the individual, if the individual becomes immunocompromised or the immunity of the patient falls, then this latent tuberculosis or this latent infection can become reactivated. So, in that case, the TB can get reactivated. So, it is very essential to treat a latent tuberculosis so that it is completely cured. Now, for the treatment of latent tuberculosis, only 1 drug is used. Isoniazid along with the vitamin B6 is given for 6 to 9 months, or rifampicin is given for 4 months. So, this is the treatment of active tuberculosis and latent tuberculosis. The first line drugs are used in this treatment. Now, let's discuss pharmacology of second line antitubercular drugs. Now, let's discuss pharmacology of second line antitubercular drugs. Now, as discussed earlier, these drugs are less effective and more toxic. Now, second line drugs are used as reserve drugs, and these are used in the treatment of TB resistant to first line drugs. So, second line drugs are used in the treatment of multi-drug resistant TB or MDR TB. Now, second line drugs are also used if one or more of first line drugs are not tolerated by the patient or first line drugs are contraindicated in the patient. Now, second line drugs include ethionamide. Now, ethionamide interferes with the synthesis of mycolic acid. Now, ethionamide is an anti-tubercular drug with moderate efficacy. Now, this drug shows poor tolerability due to these many adverse effects like anorexia, that is loss of appetite, nausea, vomiting, salivation, metallic taste, then aches and pain, peripheral neuritis, behavioral changes. It can also cause impotence, menstrual disturbances and goiter. So, since it has a poor tolerability and it has moderate efficacy, it is used only in the treatment of multi-drug resistant TB. And prothionamide can be used as an alternative to ethionamide. Now, next drug is cycloserine. Cycloserine is tuberculostatic. Now, as already discussed, one of the layers in the cell wall of mycobacteria is the peptidoglycan layer. Now, this peptidoglycan layer, it is made up of two types of building blocks, N-acetyl-glucosamine and N-acetyl-muramic acid. Now, these two building blocks are found to be extremely or extensively cross-linked. Now, this extensive cross-linking provides strength to the cell wall. Now, what the cycloserine does is this, that cycloserine inhibits cross-linking of peptidoglycan layer of the cell wall. Thus, peptidoglycan layer is incompletely formed. So, this is the mechanism of action of cycloserine. It inhibits the synthesis of peptidoglycan layer of the cell wall of Mycobacterium tuberculosis. Now, cycloserine primarily causes neurological adverse effects like neuropsychiatric symptoms like sleepiness, headache, tremor, slurring of speech, and rarely it can cause seizures also. Now, cycloserine is also used only for the treatment of multi-drug resistant TB. Then terizidone. Terizidone can be used as an alternative to cycloserine, and terizidone consists of two molecules of cycloserine. Now, the next second line antitubercular drug is the paraamino-saliculic acid, in short PAS. Now, as we all know that bacteria requires folic acid. Bacteria synthesizes folic acid while human get the folic acid from diet. Now, folic acid is essential for the synthesis of purines and pyrimidines, which are further required for the synthesis of DNA. Now, paraamino-salicylic acid inhibits folate synthase. So, it causes inhibition of this enzyme folate synthase. Now, this further inhibits synthesis of bacterial folic acid. So, DNA cannot be synthesized. Now, paraamino-salicylic acid is tuberculostatic. It does not kill mycobacteria, but it inhibits its growth. Now, PAS is used in combination with other drugs for the treatment of multi-drug resistant tuberculosis primarily because PAS delays development of resistance against antitubercular drugs by the bacteria. So, primarily it is used for the prevention of development of resistance by the bacteria. Now, acceptability of PAS by the patients is very poor because of frequent anorexia, nausea, epigastric pain. It can also cause rashes, fever, then malaise, goiter, hypokalemia, liver dysfunction, and rarely it can also cause a blood dyscrasias, that is a disorder of the blood. Then next category of second line antitubercular drugs are the fluoroquinolones. Fluoroquinolones like ofloxacin, levofloxacin, ciprofloxacin, moxifloxacin. Now these drugs they inhibit bacterial enzyme DNA gyrase and topoisomerase 4. So, inhibition of these enzymes prevent the replication of bacterial DNA. So, DNA does not replicate, bacterial cells cannot multiply in the presence of fluoroquinolones, and therefore the fluoroquinolones, they exert bactericidal effect. They kill Mycobacterium tuberculosis. Now, fluoroquinolones are well tolerated and they can be used as an alternative to first line antitubercular drugs. But fluoroquinolones are used only as a component of the regimen that is used for the treatment of multi-drug resistant TB. Now, adverse effects of fluoroquinolones are it produces gastrointestinal adverse effects like nausea, vomiting, anorexia. Then CNS adverse effects like dizziness, headache, restlessness, anxiety, insomnia. And rarely fluoroquinolones can cause tremors and seizures. These can also cause rashes and photosensitivity. Therefore, exposure to the sun should be avoided. And they can also cause tendon rupture. So, this is the pharmacology of second line anti-tubercular drugs. So, this is all about the pharmacology of first line and second line anti-tubercular drugs. Complete comprehensive overview. Please note, information in this video is only for academic informative purpose. For use of any of these drugs or for the treatment of tuberculosis, consult your physician. If you find the video useful, kindly like, subscribe and share this video. Thanks for watching this video.